All right, everybody. Thank you so much for joining us today. My name is Liz Stewie. I'm the Training and Technical Assistance Manager with Violence Free Colorado. And our goal here today is to talk about domestic violence medical reporting options and community referral steps. So please feel free at any time to type a question in the chat box. I would love any questions that you have. You can also, it looks like the setting was defaulted to mute everybody. So if you want me to unmute you so you can ask a question live, please just type in the chat box and I can unmute you. And also, if anybody is having any trouble seeing my slides, please feel free to throw that into the chat box as well. So we are going to get started today. So the very first thing we're going to do is I am going to put a link into the chat box. All right, there we go. And so if you could please click on that link, what it is it will take you to an office forms survey. It's just a couple of questions and it should not take very long at all. We are using these first couple of trainings that we're doing to really gauge and assess and make sure that we are making these trainings as useful as possible. So your feedback will be used to improve the presentations when we talk to future folks in the medical field. Oh, folks are saying, okay, let me put it into the chat again. Thank you for noticing that. Hopefully that came through. If you can see the message I just sent in the chat, if you could let me know, that would be awesome. Got it, great. Thank you, Lindsay. I appreciate that. So I'm just gonna give you a couple of quick minutes to fill this out. Should be nice and easy, and then we'll get started. All right, we're going to go ahead and move on with the slides, but please feel free, if you're finishing up that survey, please feel free to do that. So today, really our goal is to talk about medical reporting options and connecting survivors with services. So the first thing I'm going to start with is just a quick definition of domestic violence. A lot of you have probably already seen this, and this is kind of a review, but I think it's helpful sometimes if we have shared language to what we're talking about. So this is the definition that we use at Violence Free Colorado. And we are the statewide domestic violence coalition. You may know us from our previous name of Colorado Coalition Against Domestic Violence. We are still that coalition. We changed our name to reflect the future that we are trying to build for Colorado. And we're a nonprofit voluntary membership organization, and our members are made up of domestic violence organizations, dual domestic violence sexual assault organizations, and community partners all over the state. So this is the definition that we use when we're talking about domestic violence. This is not necessarily the legal definition in every jurisdiction that you might be working in. This is the definition we use that we find is most helpful with survivors. And since the patients and clients that you'll be working with are experiencing that, we find that this is the most helpful. So the definition of domestic violence that we use is that it is a pattern of coercive behavior used to gain power and control over another person in an intimate or formerly intimate partnership or relationship. Folks can be survivors of any gender. Folks who use abusive behaviors can also be of any gender. So all of our programs and services that we're going to talk about today are available to folks regardless of their gender. So this is the power and control wheel. And this is a really helpful tool if you want to learn a little bit more about domestic violence, you want to dig into the topic a little deeper after this. So the power and control wheel was developed in the 80s and 90s. It's oftentimes called the Duluth model because it came out of support groups that were happening for women at the time when this was first created. It was just with women survivors whose partners were receiving, at the time it was called batterers intervention. It's called a lot of different things across the state. In Colorado, it's called offender treatment. And so they were, their partners or former partners were receiving that treatment, and they got together and talked about their experiences. And so that's what this model comes out of. So the goal of this model is to really share some of the most commonly reported experiences of domestic violence. This is not an exhaustive list. This model has been updated to be more gender neutral, but it is not a complete list. It's just a good starting point for a lot of folks. And so it just has different types of abuse that folks might experience. And then on the outside is physical and sexual violence. This is also used to demonstrate that the majority of abuse that people report experiencing is not physical or sexual in domestic violence relationships. That definitely happens, unfortunately, but there's a lot of other things that happen, emotional things, using economic threats or economic abuse, using children. And so we just want to highlight the different ways that domestic violence might look. There are also lots of different versions of this. So if you're ever in a place where you need something easy to use, I recommend Googling power and control wheel and then the group that you're working with. So there's a specific teen power and control wheel. There's an LGBTQ community power and control wheel. There's an indigenous community power and control pyramid, because in a lot of indigenous cultures, the wheel is a sacred object. And so that utilizes a pyramid shape to demonstrate this. So there are a lot of different options out there. There are also a lot of different languages out there. So this is a handy tool if you ever need it. So why are we talking about domestic violence with folks who are in the healthcare field? There are two main reasons. One, and you already know this, so I'm not telling you anything new, but you're already seeing folks who are experiencing domestic violence. You are probably seeing folks who both disclose to you that they've experienced domestic violence and also folks who don't disclose to you. And so we know that survivors are already using your services. And so that's why your work is so important in their lives, and knowing about domestic violence can help them. And secondly, is that it makes a really big difference. We have a lot of evidence-based research, and also just from my own background, I worked in direct service for a long time. I was a shelter manager for a domestic violence shelter. And before that, I was actually a health and wellness advocate. And so my job was to go with survivors to health appointments, to help them coordinate, to find resources to pay for health needs. And so firsthand in my work, I have seen what an incredible impact that folks all throughout the medical field have on survivors. That is both their providers, their doctors, their nurses, the social workers, the navigators, everybody who's involved in the healthcare systems. I've seen different folks in different roles have a really big impact in helping a survivor get to safety. So we talk about it because it really matters. And the work that you do is so crucial that when you add a lens of domestic violence to it, you're even more effective in getting people connected to resources. So this is just one survey that was done with women, but it said that women who talked with their provider about abuse were 2.6 times more likely to exit an abusive relationship. That is really significant. And so the work that you're already doing and the work that we're hoping to support you with more information today has a really big impact on survivors. So we're going to talk a little bit about disclosure, but I want to make a point real quick that what we've learned in the last 5 years or so is that it is less important whether or not somebody discloses to you that they're experiencing domestic violence, and it's more important whether or not you give the person access to resources. And that's what we often call like a universal education model. So we see a lot of clinics and offices and hospitals across the country are actually moving towards a universal education model because even if somebody does not disclose to their provider that they're experiencing abuse, but they, you go home with a brochure or they get some information from their provider, they're still more likely to get to safety faster, even if they never tell their provider they've experienced abuse. So we use a lot of disclosure models, like navigators ask questions directly about abuse. And that's another great way to get resources to somebody, but it's also helpful to kind of try and get resources to as many people as possible. And again, just want to remind you, please feel free if you have questions to put them in the chat box and let me know. I'd be happy to answer questions at any point. So what does domestic violence look like in healthcare? So this is where we put this information in just to address some of the stereotypes that I'll admit I myself had before I worked in the domestic violence field. And we tend to think about domestic violence in a healthcare setting as being black eyes and broken bones, which is absolutely true. It can be that sometimes, but we're also learning more and more every year about the impact of trauma on somebody's health. And so domestic violence can look like a lot of different ways. It may not just present in a medical setting in the ways that we're maybe used to it or expecting it to present. One thing I always say is that when I managed a domestic violence shelter, we went through digestive related issue, over-the-counter medications very, very quickly. So things like Imodium, Tums, Pepto-Bismol, we went through that stuff so fast. I was always begging community members to donate it to us because we could never afford to keep enough of it in stock. And it took me a little bit and learning a little bit more about trauma when I was in my role a little bit longer to really make the connection that stress and trauma has such an impact on the human body in a lot of different ways. And so we just share this for you to see. These are some of the ways that have been documented that folks who are experiencing domestic violence, that violence has impacted their health. And we see it in physical health, we see it in reproductive health, we see it in mental health, we kind of see it across the board. So another interesting study, this was done through the Domestic Violence Hotline. And again, this was only done with women, but I think that the statistic would hold with survivors of another gender too, in my own experience, is that not only does domestic violence impact somebody's health when they're in an unsafe relationship, that relationship itself prevents folks from getting access to healthcare. So in this study, 70% of abused women reported that their partner prevented them from accessing healthcare, compared to only 2% of non-abused women. And as a domestic violence advocate, my red flag radar goes up, and I wonder how healthy a relationship could be if somebody is preventing somebody from getting healthcare. But that is a different issue altogether. So really, another reason we tend to point this out is because when you do have somebody, who's receiving services from you, either in your office or through telehealth, the fact that they are receiving those services with you at the time is pretty significant because survivors do face a lot of barriers in getting to appointments and making appointments and feeling comfortable and safe with appointments. So, we want you to take advantage. If you have somebody who's receiving services from you, it's a great time to talk about resources because they are there with you. So I'm just going to pause real quick if anybody has any questions. Great. So the next thing we're going to talk about is mandatory reporting for folks who are licensed medical professionals. So this law was changed in 2017, and it was done in a coalition between folks who provide domestic violence services and folks who represent the interests of medical providers. So it was a joint effort, and there were a couple of goals in changing the adult mandatory reporting law. The first one was to allow medical professionals to respect patients' wishes if they disclose that they were experiencing domestic violence. We actually heard from several medical professionals that they were really concerned because they were actually violating the existing adult domestic violence mandatory reporting law in order to keep their patients safe, because their patients had disclosed that they thought their abuser would seriously harm or kill them if it was disclosed to law enforcement that they were experiencing this abuse. So we heard from some providers who were keeping that confidential and really wanted the option to be able to do that if that was what they determined was in the best interest for them and for their patient. Another reason is to just provide autonomy and trauma-informed choices for survivors. So being trauma-informed, for us in the domestic violence world, part of that is really respecting the choice and the decisions of survivors. And then finally, we wanted to restore professional discretion for licensed medical professionals or licensees, because we really trust in that discretion that they have and wanted to kind of return that choice to them and the person that they are working with. So this law just applies to adults, so folks who are 18 or older, and domestic violence specifically. So it does not change anything about your mandatory reporting for child abuse, known or suspected, for sexual assault, for serious bodily injury, gunshot wounds, vulnerable adults, or injuries related from other crimes. So this is pretty narrow in the fact that it's just adults 18 or over and folks who are experiencing domestic violence. So I apologize if you can hear jets over my house right now. I don't live very far from Buckley Air Force Base, and so sometimes we get jets flying over. So who does this law cover? So this law specifically addresses folks who are physicians, physician's assistants, anesthesiologists, or anesthesiologist assistant. So again, in the broad scope of people who are providing medical services, it is pretty narrow. And the reason it is narrow, it is because the law, before the law was changed, these were the only folks who were required mandatory reporters for adult domestic violence. So for example, nurses, before this law, nurses were not mandatory reporters for adult domestic violence. So this does not change nurses' reporting laws related to adult domestic violence. We do say that if a nurse or nurse practitioner does want to make a report to law enforcement about domestic violence in a person they're seeing, that they work with the medical licensee that they operate under or that they operate with to make that report in order to remain compliant with their HIPAA requirements. So that is just a recommendation that we have, that they work with somebody for that person, the medical licensee specifically, to make that report. So the goal of this law kind of has two outcomes that we'll go over in a little bit more detail, whether you report to law enforcement about adult domestic violence or if you don't. And so if you do choose to make a report, and go ahead and go to that next slide. So if you do choose to make a report to law enforcement, we recommend, well, the law requires that you confidentially notify the survivor of your intention to call law enforcement before you make the report. And this is to allow the survivor to safety plan for any kind of reaction that the person who is using abusive behaviors in their life might have. We know that for some abusers, it can really escalate physical abuse. And so we want the person to have a heads up so that they can safety plan around that, which leads into the second part of the requirement. If you are a medical licensee and you choose to report, the second part of the requirement is that you make a referral to a confidential victim advocate. And that is that person who can really help with safety planning. And I'll talk in a little bit more about exactly what advocates do and how you can connect with them. But for the purpose of the law, this is the requirement if you are choosing to make a report. If you choose not to make a report, you do not have to. That is your choice, professional discretion. We recommend making that decision in partnership with the person that you're serving. But even if you choose not to make a report, you're still required to make a referral to a confidential victims advocate. So no matter which decision you make, you're still going to make that referral. So we recommend that folks make that referral first, and then follow through with whichever part, whether they're choosing to report or not, as the next step, because you're always going to have to make that referral. And the law also gives professional and personal immunity to folks who are covered under this law for the outcome of the report. So, the physicians are not responsible for the outcome of whether or not they choose to report. Does anybody have any questions about choosing to report or not? Great. So documentation. This is what we recommend. If you choose not to call law enforcement, we recommend that you document the patient or client that you're working with, what you observed, if they made a request specifically not to call law enforcement, and then that referral was made. So we're just making sure that you're documenting that the referral was made. And the questions, will we get a copy of the slides? Yes, you will, absolutely. We are also recording this, and so if you have colleagues or other folks you work with who this might be helpful for in the future, we'll have that available as well. And so if you are calling law enforcement, again, you're going to document what you observed, document that you confidentially informed the victim that you made the decision to call law enforcement, and again, your confidential advocate referral is made. So I do know that some places have moved towards universal education because it helps them make sure that they are making advocate referrals in every case necessary. So that's something to consider as well. But I do recommend documenting that for your own records. So the required referral, like I said before, you have to make that no matter what decision you make about reporting. We really encourage folks to have a phone available in their offices at all possible. A couple places I've worked with have, an empty office where they have a phone available, or they have kind of a private area in the back of their lobby or something where a phone is available, because even though cell phones are more readily available than ever before in our modern world, they are also very easily tracked. And so a lot of survivors don't feel comfortable using their own phone to reach out for services. So it's really helpful if you have some kind of phone access available in your program. And again, this law we're specifically talking about, the referral, is mandated for domestic violence survivors. You may also want to refer to sexual assault organizations. A lot of programs in the state of Colorado are dual agencies, meaning they serve both domestic violence and sexual assault agencies. Especially in the metro, we have several big programs that serve both. But also don't don't feel like you have to you have to decide exactly whether something is domestic violence or sexual assault, because it can get a little confusing. For example, sexual assault is a commonly used tactic within intimate partner relationships, that is used as power and control. And so then it would also, we would also consider that domestic violence, because it's behavior, use a pattern of behavior used to coerce, and have power and control over another person. I throw this in there just to mention it, but also, if you refer somebody to a domestic violence advocate, and the advocate is talking to them and they think, hey, this person might also want to have a sexual assault advocate, a lot of folks have both. That is totally fine. The whoever you make the primary referral to can connect that survivor, to resources. So don't think too hard about who you have to refer to. Just as long as they get to one or the other, the advocate can support them, because the advocacy skills are very similar between the two. There's a little bit of difference, which is why we have folks who specialize in both, but advocates are still advocates, and they're still great working with survivors, and they'll get them to where they need to be. And so also, not only the medical licensee does not have liability attached to their decision whether to report or not, they also don't have any liability to the services that are provided after they make a referral. So the next thing I want to talk about is, what does an advocate do? So there are actually, I'm not going to dig too deep into this because I could spend a lot of time talking about it. There are actually 3 different kinds of advocates in the state of Colorado. There are community-based domestic violence advocates, which is what we're talking about today, which is the highest number of folks in the state of Colorado are community-based advocates. There are also, a second type are law enforcement-based advocates. So these could be victim witness folks, specific domestic violence and or sexual assault victims advocates that are housed within district attorney's offices or other law enforcement offices. So those are another great resource for survivors. Those are a great referral to make especially if you're choosing to make a law enforcement report, or if the survivor is already involved in some way with law enforcement. Those advocates do also oftentimes respond on the scene. Law enforcement victim advocates will respond on the scene and or will receive contact information from responding for officers or EMTs about the situation. So it's a little bit easier for those survivors to get connected with those advocates versus community-based advocates. We want everybody to know, because only about, there are a couple of different statistics, but about 80% of survivors don't get involved with the law enforcement or the legal system while they're seeking safety. So a lot of folks won't have that referral available to them. And then there are also treatment victim advocates, which are advocates that are supporting survivors when they have a former or current partner who's receiving offender treatment for domestic violence. So just so you know, there are those 3 kinds of advocates. Community-based advocates are a wonderful first point of referral. That's why we're talking about them today, because those advocates can also get folks connected with other types of advocates if they are needed. And a lot of times, I used to work as a court advocate, and I don't think I served a single survivor I was with a community-based program. I don't think I worked with a single survivor who didn't also have a victim advocate who was part of the law enforcement system, because they really do have a lot of specialized knowledge about the legal system that's helpful. So community-based advocates are really unique in Colorado, that they have confidentiality that is much higher than most other social service professionals. Advocates in Colorado have legal privilege, similar to an attorney-client privilege. Advocates have legal privilege that is just as strong. And so if you have a survivor who's really nervous about somebody finding out that they're receiving services, community-based domestic violence advocates are a great place to start. We do not report any personally identifiable information to anybody, including our state and federal grantors. We can respond to most subpoenas in a way that we don't have to share information. And we actually, domestic violence programs also have some protections that allow them to keep, in many circumstances, to keep law enforcement off of their property, out of their offices or out of their emergency shelters. If you have somebody who is fearful for that, this is a great referral and place to start for that. So advocates do a little bit of everything. So really an advocate's goal is to meet a survivor where they are to help them get resources to get to safety. And that's going to look really different for everybody. For some folks, that may mean safety planning so that they can stay where they are in their current relationship. Advocates can help with that. Might mean leaving where they currently are. Most programs have emergency shelters and or some kind of longer term transitional housing or rental support or something like that. And so they're really whatever the survivor needs to get to where they want to go, that's what the advocate is going to connect them with. So advocates are great with connecting folks with community resources. And they do have, not every program in the state has a 24-hour hotline, but all of the metro programs do have 24-hour hotlines. So they are easy to reach out to. And that confidentiality does attach the moment a survivor calls an advocate. A couple of other things that I want to point out that have come up in questions lately are also that community-based domestic violence organizations do not collect any kind of data or information regarding somebody's immigration status, nor do they have to report on anybody's immigration status. So no matter what somebody's status is, advocates can serve them. Folks don't need to have any kind of ID or identification or paperwork. Folks do not even have to give us their legal name if that's not something they feel safe doing. So it is really very survivor focused and survivor driven. Also, most programs have a language line that they can utilize to talk with folks in different languages and or have interpretation services available. Most of the programs in the metro also have bilingual English-Spanish advocates. So if that is something that somebody you're working with needs access that way, that is available as well. So here is the best two referral points that I can give you. So the first is the National Domestic Violence Hotline. So this hotline is answered 24/7, available nationally, but they can connect directly to any program in the state of Colorado. So they don't, it's not like the person calls and has to get another phone number and call another person. They can direct them, they can connect them directly to a crisis line. So this is a great option for folks who you're not exactly sure where they want to be, or if we use this hotline a lot, especially if somebody is in a rural community where their program doesn't have a 24-hour hotline, this is a great option. They also have language line services. They have I think they have close to 200 languages available. So it's a really good access point. They also have a website, which is thehotline.org, that has 24-hour chat services available. So if somebody isn't safe to make a phone call where they are, but they are safe to use a smartphone or a computer, they can chat with an advocate 24/7 through that website. So the second resource is our website, which is just violencefreecolorado.org. And you can click on the counties to see all of the different programs that are available in the counties. So especially in the metro area, there are a lot of culturally specific programs. So there are what we call more mainstream programs that all of the programs serve everybody, but we do have some culturally specific programs that that focus on and specialize in serving certain types of survivors. So, for example, Latina Safe House in the Denver Metro, great resource for folks, especially if they are wanting an advocate who has specific training and experience in serving Latinx populations. We have organization called DOVE, which is Deaf Overcoming Violence Through Empowerment. So if you have, if you're working with someone who is deaf or hard of hearing and wants an advocate that has that specific experience, that is available too. The initiative is a more general organization for people with disabilities. There are just a lot of options. So I recommend clicking on the county that you're in and seeing what's available in your county. So the kind of the caveat to that is that there isn't strict service areas for survivors receiving services. Honestly, it is really focused on what's safest for survivors. Now, there are some programs that are more county specific. So for example, if a survivor lived in Denver but worked in Boulder and they wanted to receive domestic violence services from the Boulder program, they absolutely could. They could get safety planning, they could talk to somebody on the hotline, but they may not qualify for example, for their housing or rental program because some of those funds are community based and based on specific counties. So there is some benefit for folks using their own like home counties, but it isn't required. And especially, you know, in the metro, we see, you know, folks who live in Denver, but they're receiving services from the Aurora program because that's safer for them and they're less likely to run into their abuser in Aurora or vice versa. The location shouldn't stop somebody from calling if that is the best spot for the survivor to receive services. And so either of these would count as your warm referral for the domestic violence mandatory reporting law. They're great resources to have. So I also want to mention that the hotlines that every program has available, they are not just for people who are in crisis. Sometimes hotline or crisis line can be kind of misleading. So family members can call if they have questions about like, you know, I think my sister is in a domestic violence relationship. What can I do to support her? That call is totally appropriate. Community members can call those hotlines and ask for brochures or resources or ask a question. You can call a hotline and ask just a very broad or general, like I'm working with a family that has, you know, 3 kids under the age of 3, like what resources do you have available for that family? So you're also welcome to utilize those phone numbers. Some programs also have an administrative line that we have listed on our website, which that is even better. If you feel more comfortable just calling kind of a business line that's only open during business hours, you can do that as well. Does anybody have any questions about making referrals? So I did want to mention the word warm referral that we use. Really, that is meant to indicate that it is just a little bit more information than just a strict handoff. So instead of just handing somebody, you know, a card with a phone number on it, you can say, oh, you know, I'm giving you the card for this organization. They're actually just, you know, a couple of blocks over from us, and their advocates are confidential. You know, we have a phone down the hall if you want to call them now, or something along those lines. Just gives you a little bit more information, and that is shown to make folks more likely to actually follow through with contacting and information in the referral. It could also be helpful. Sometimes we just ask, like, you know, if somebody seems reluctant or nervous, I'm just asking, like, do you have any barriers reaching out for help right now? And that's where you might hear that they don't feel safe using their phone, or they don't have access to a phone at all, or they're already living in their car, and they don't have access to a phone line or resources or anything like that. So sometimes that can be helpful as well. So here's some things. So these are considerations for you. These are recommendations. These come from our perspective as domestic violence advocates. But we think that they are things that folks should at least think about before deciding whether or not they're going to make a mandatory report of domestic violence. So we kind of our core central philosophy is survivor empowerment. And we really believe that survivors know what is best for them. And that has actually been played out in research. So there is a national kind of movement to collect information. You may have heard of a lethality assessment, which was started out of the Maryland Domestic Violence Coalition. And what they did was they collected information from state fatality review boards. So many, if not all, states have a domestic violence fatality review board. A lot of them have child fatality review boards. And so what these groups do is when there is a domestic violence fatality, they review the information in the case. They talk to families, they talk to friends, they talk to law enforcement, they talk to advocates when they can. And that information was then compiled into a list of red flags, essentially, for indicating that a situation might be lethal. And the number one thing that they found in this research that they did was that when the survivor themselves believed that a situation would be lethal, that was the highest indicator that the situation would indeed become lethal. So that's just an example of one of the reasons of why we feel so strongly in believing survivors. And so that really plays out. So if somebody tells you that a situation that they're worried that their partner might kill them, or that a situation feels lethal, that's a very serious thing to say. And so that's somebody we, from our perspective, we want to get connected with services immediately, if possible. But again, of course, it is up to that person whether or not they seek to receive services from us. And just again, I want to mention, folks who use abusive behaviors can respond really differently. Some folks do not necessarily respond negatively to law enforcement, but there is a significant enough group of folks that do. Which is why the law includes the provision that you have to notify the survivor confidentially before you make the report. And again, that is just so they can safety plan. Maybe that means if you're going to call law enforcement that evening, maybe that means they need to get the kids out of the house for the evening, or that they're going to go stay with their mom, or they're going to, call a domestic violence advocate when maybe they weren't necessarily planning on coming into services yet. But that might make the situation more emergent for them. So, whatever your decision, that confidential notification is really, really important for somebody's safety. And thank you for the comment that survivors know what's best for them. Yeah, they really do. Survivors have a lot of wisdom and knowledge, and they've kept themselves as safe as possible for the duration of what they've experienced so far, and really taking a strengths-based approach and saying, okay, you've survived this far. That in and of itself is a major accomplishment. How can we support you and what you're already doing? How can we give you additional resources to meet your goals in order to get to safety? Is really the best approach that we've found to the work so far. So a quick review of mandatory reporting laws that, we really want to put that professional discretion back on folks who have a medical license, so they can choose whether or not they're making law enforcement report. We notify the survivor beforehand, and in either situation, we're going to make that referral to a confidential community-based advocate. So here is, a lot of times folks ask me, like, what do survivors need from us? And so this is based on a lot of survivor feedback and a lot of experience, and then also a lot of research. So the best things that you can offer a survivor in the moment are, number one, safe and non-judgmental listening. It seems kind of straightforward. And again, this is why we love partnering with folks who are in the medical field, because you already know how to do this, right? This is something that you are already doing. And so you have these skills already to provide kind of a safe and non-judgmental space for somebody to share their experiences. And so again, it's why it's such a great place to add on the second one, which is resources. We did in 2019, we did a statewide needs assessment. And one of the biggest things that we heard from survivors who took our survey was that before they got connected with services, even some of them who had been experiencing domestic violence for years had no idea that domestic violence services existed. These services tend to be kind of invisible until you need them. So sometimes people don't know. And it's another reason that we promote the universal education model, is because even if you give resources to somebody who isn't experiencing abuse, they now have those resources for their friends or family who might come to them and say that they're experiencing abuse. So resources, connecting that person. And again, it's why the work of what navigators do is so crucial and so important in people's lives, is that connection to resources really makes a big difference. And it really does show up in the research that folks are more likely to get to a safe place sooner. So a couple of tips in talking about domestic violence. First, I just want to acknowledge that talking about domestic violence is not easy. And I've been doing it for over a decade, and I've learned some things, but it's never gotten easy. So if you feel uncomfortable, or if talking about things like domestic violence and sexual assault are hard for you, that is totally normal. That is totally okay. We share these tips to kind of help folks deal with that. But we do want to acknowledge that is very real and very true for a lot of people. So first tip is not to set yourself up by failing. Sometimes when we have to ask somebody something that is awkward or uncomfortable, we kind of try and hedge at the beginning of the question. And I know, because I've done this too, and I'm constantly working on not doing this anymore. But when you have to, like, for example, if you're a navigator and you're asking direct questions about people's experiences, or if you're a provider and something has led you to want to ask a direct question about it, don't set yourself up for failure from the beginning by saying, I'm sorry, I have to ask this, or I know this probably doesn't apply to you. So those are things that make us as folks are asking this question a little bit more comfortable, but in the long run, they don't necessarily encourage survivors to feel comfortable disclosing. Talking to the person alone. This actually makes a big difference. Some of the clinics that we've worked with and learned from over the years have actually moved to a policy of meeting with adult clients for at least 5 minutes alone of every appointment. And so this is just that we know that abusers will go with folks a lot of times to the ER or to doctor's appointments. And so folks are never going to be able to share with you their experiences or feel comfortable receiving resources if they're not alone. Again, we know this isn't always possible. We know that, sometimes folks have their children with them. If possible, it's best to talk to the person alone, but that's not always going to be possible. So it's a best practice, but we do the best we can in the situations that we have. So don't focus on disclosure. So the goal is for you to share information with the person, not to get information from them. So whether or not somebody discloses to you is not going to change whether or not they receive services, as long as you're giving them resources. So again, this is why we support the universal education model. And this is why sometimes it can be, you can feel like you have to dig a little deeper, get more information. And then if that's important for another reason, based on the conversation you're having or based on somebody's, the medical services you're providing, that's totally normal. But you don't necessarily have to get all of the details about somebody's situation. Somebody discloses a little bit to you. Maybe they just say, I don't really feel safe at home anymore. And that's all that they say. That's okay. As long as you're giving them resources, they're still likely to get to support. In fact, there was one group that did some research at a clinic that showed even folks who took resources like a brochure from their provider and then dropped it in the trash can on their way out the door, those folks were still more likely to get to safety sooner than folks who didn't get resources at all. So even if somebody says, oh, I can't take these right now, or if you see somebody throw them away as they're leaving, you still helped them by letting them know that that resource is available. And I recommend that folks have a plan for dealing with difficult disclosures as a team. So who, amongst your coworkers or your supervisor, who do you talk to when there's been a difficult disclosure? So secondary trauma is very real, as you know, from lots of other things. And hearing somebody's story and experience of abuse, it can definitely lead to secondary trauma. And one of the best ways to counterbalance that secondary trauma is with reflective supervision. And really, that's just a fancy term for talking about it with somebody else. A supervisor is a great person to talk to if that's available to you, but we know based on shifts and when people work, that's not always an option. So is there another person who's part of your team who has the same confidentiality, who has access to that same information that you have that you could share a little bit with? And so planning on how you're going to do this beforehand can be really helpful. I worked with one group once who had a policy if somebody had a difficult disclosure, they had somebody in their team that they could call and ask them to cover their desk and their phone for 10 minutes while they took a quick break to breathe and to walk or whatever they needed to do. So that's something else to consider. If there's a way that folks can get a break right after something like that has happened, that can be really helpful. And my final tip is just to watch for your body language. Humans just communicate so much through our bodies and our faces, and survivors, pick up on those same clues too. So the more you can have relaxed and non-judgmental facial and body expressions, the better it's going to be for the survivor. Anybody have any questions about those? Great. This is just a quick slide. You'll get a copy of those. I just wanted to share some examples of avoiding victim blaming language, which honestly, with medical providers, it really hasn't, we talk about it with a lot of different professional folks. Usually folks already know this, but just as a reminder that, using supportive or affirming language can be really helpful. People who have good first disclosure experiences, meaning that whoever they first share that they've experienced abuse with, if that person validates them and says they believe them, that person is more likely to have better long-term outcomes. So you won't necessarily always be the first disclosure, but we want to just practice using supportive language just in case we are, and because even if it's not a first disclosure, it's still really helpful for a survivor. So these are probably the three things I say the most in my direct service work is, thank you so much for trusting me with your story. A disclosure is actually a show of trust. If somebody is sharing their story with you, that means on some level they've decided to trust you with really vulnerable information. So this can be a really helpful phrase to share with somebody. Oh, that's a great question. So how does CPS approach these conversations when investigating situations of domestic violence with children in the home? So that could be, a 3-day training in of itself. And the CPS has a domestic violence best practices guide. I think I'm saying that title right. It's on our website. And so they have, Colorado CPS does a lot of work of understanding domestic violence in the intersection with child abuse. And so I do some training with them. The domestic violence program, DVP, is actually housed within the same agency. So they do a lot of work and support, but they have a whole practice guide on having these conversations, which if you're interested in, you can find on our website or on their website too. I'm certainly not an expert on that. I have never been a child welfare officer before, but they do a lot of training and work around that. I hope that answers your question. If it doesn't, please feel free to ask more. So supportive language, again, these are just some more examples. I wanted you to have just some words. Sometimes it can be helpful if you're feeling nervous about this to have some words, but at the end of the day, just like all other people, survivors respond to authenticity. So the more you can be truly yourself and be authentic in these conversations, the more a survivor is going to feel that you're trustworthy and feel supported by you. But these are a great place to start, especially if you know anybody who's new to having these conversations. Scripts can be helpful. So now let me grab the final link for you. So that should be in the chat box now. Again, this is just kind of a follow-up to the survey you took before. This is really, really helpful for us in deciding how we want to do these kinds of training moving forward. So I'd appreciate it if you'd fill that out. And I'm just going to give you a quick couple of minutes to work on that. All right, please feel free to keep working on those. You can finish your surveys and submit them after we're done here too. Just wanted to say a couple things in closing. First of all, I'm gonna put in the chat, I also put our website, specifically the page that is about this law. If you wanna learn any more about it, or if you have any questions, that page is a great place to start. But also I'm here as a resource for you. So this is just a quick slide for review for the mandatory reporting law that we've went over. And here's my contact information. So I frequently answer questions from our community members, and so I would be happy to answer any questions, especially if you have a specific situation, if you want to throw some details at me very broadly, you know, a family of 3 is looking for this or something like that, to ask me a question, I would be more than happy to respond to that. Or if you have any additional training requests or support that you need around domestic violence. So please, for those of you who haven't finished, please finish up that survey and submit that. And I thank you so much for your time. I know how valuable your time is, how busy you are, especially right now with coronavirus, everything that's going on. And we just appreciate so much all of your hard work and everything that you do for survivors. So thank you, and I hope you have a wonderful day.